Can you hear me? Hello. Can you hear me?
Yes, sir.
Okay. Good morning, everybody. I am delighted to introduce Dr. Naresh Vadlamani. He will enlighten us in psychopharmacology in special populations. He has passed his MBBS from Gandhi Medical College, Hyderabad. He has passed his MD from Osmania Medical College, Hyderabad. He has presented research papers for Bhagwat Award and SIP 1999. His main interest is in suicide prevention, mental health Act 2017, and critical appraisal of research articles. He has represented South Zone as wicketkeeper and lifted the national cup twice. He had organized and conducted suicide prevention awards, suicide prevention awareness run at Hyderabad. Since last 5 years, he is doing this activity. Publication on his names are Mental Health Act 2017 and Suicide, Telepsychiatry, OPD, Suicide Risk Factor in Rural Women. He was ex-EC member at IPS. He was also Honorary General Secretary, Indian Psychiatric Society South Zone Branch. He was ex-President Hyderabad Psychiatric Society. He was ex-General Secretary IPS, Andhra Pradesh. He was ex-chairperson School Mental Health Committee, IPS. He was ex-associate professor at Bhaskar Medical College, Telangana. Now, he is working at Chief Consultant Psychiatrist, Columbus Hospital, and he is also associate professor at Apollo Institute of Medical Science and Research, Hyderabad. So he will enlighten us pharmacology in special population, like during pregnancy, how to treat the patient, during renal impairment, during hepatic impairment, in geriatric patient, in cardiac patient. What are the principles we have to see, and how we should go? Because during the renal or hepatic impairment, there will be half-life of the drug will be prolonged. So how to adjust the dose and what should we do? So over to Dr. Naresh. Thank you.
Thank you, Dr. Paresa, sir. It's really a generous introduction to my credentials. Let me start with in Gujarati. Right? Gujarata Rajana Lokoni Same Bolavawa Amantrana Patava Vanam Mane Bahumana Che. I took it from the Google translation. What I mean is that I'm really honored to be invited as a speaker in front of Gujarati psychiatrists. Right. Thank you very much, sir. And I'll just share my screen. Are you able to see my screen?
Yes, sir.
Okay. So I'll put it into full slideshow. Okay, right. Now, initially when I was asked to speak on special population, I was looking for definition, because in psychiatry, everyone is special and we are going towards personalized medicine as well. So what it means is every patient who comes in front of us, he's a special person. So what is special about this special population? Right. So, I mean, I was just looking into all the kinds of literature and search, and then, I mean, if I talk about psychopharmacology of special population, it means that I'm talking about psychopharmacology of everyone, all of psychopharmacology. So that would take days and days, and initial, we have to divide it into different parts of psychopharmacology. But then let me see what justice I can do to whatever little time which I have. And coming to the special population, I mean, women are one, pregnant women, children, elderly, and comorbid illnesses. So these are the people whom we consider as special population. But actually, if I put men also there, then it means that the whole population, we are talking about the whole population. I mean, literally, it's not like I'm an expert. I have learned through several mistakes for the past several years of working in several hospitals, especially corporate hospitals or even general hospitals. And I'm sure every one of you who are here have treated several patients, and it's that your own experience and we can, I mean, initially I was thought it was like a more or less it can be like a discussion, so that I can learn from you and you can say learn few points which I can gather from evidence base. So let us see how this goes. And initially I was logged in since morning, and I have looked at the number of participants. It looks more than 90 around. So I'm sure every one of us are here experts, and let us share our knowledge as well. So let me talk about, okay, let's make it a little more interactive. Um, and I'll just ask a brief question, starts with question. Incidence of clozapine induced agranulocytosis is less in, the choices are elderly, Africans, males, HLA haplotypes, and eosinophilia. Right. So,
Sir, sorry to interrupt you, sir.
yes, sir.
So, we are going to have a poll over here. I'm
Okay,
addressing all the audience.
sure.
We are, just look for your chat box. You will
Okay,
find one link. You
right.
need to click that link, and you will be redirected to your browser. In that, you will find a slido.com, in which you need to put your name first. Then you need to join. After you join, you will see a question on your screen, and you need to answer that question. Okay, so we will take it will may take 10 to 20 seconds only to answer. Then we will see the results in a poll.
Okay,
So I request everyone to join.
answer through the chat box.
Yes, sir. No, sir, not through the chat box. Just
Yeah,
go in a chat box,
and
click on
on
the
the
link
link.
which has been in chat box,
Right.
and select the answer and send it.
We are getting the numbers. 17 have answered so far.
Yes, sir. Yes, sir.
It's increasing. 20.
Yes, sir. Increasing. So we will wait for some more a few seconds.
Okay, sure.
So we are releasing the answer. Just a moment.
Okay.
So 50% has said HLA haplotype. So now the correct answer, please.
Right. The correct answer is males.
And
Right.
so no one from the audience has passed. So
Right.
sir, we should discuss about it.
So, right.
And sir, you need to share your screen again.
What it means, yes, okay. Right. Okay. Right. So what it means is all these are risk factors. So what it means, female is a risk factor for clozapine induced agranulocytosis. So we need to remember that. Right. Woman, like I said, I mean, she is, I found out that she was a famous, she's famous in Telangana. She's a Gujarati actress, Monali Gujar, her name is, right. Okay. So women are different. They're not superior, they're not inferior, and they're not equal also. So what it means is we need to understand that they have estrogen, more of estrogen, and estrogen creates the problems. Estrogen has receptors in amygdala, and amygdala is different in males and females, and that's why men think differently, women think differently. Amygdala is a seat of limbic action as well, the emotions or impulsiveness or say reward systems with nucleus accumbens. So what it means is, yes, women are different, not superior, not inferior, and not equal to. So we need to remember that. So clozapine-induced agranulocytosis is less in women. Oh, sorry, it's more in women. Yeah. So they are more sensitive to drugs, especially drugs which can increase the QT intervals. So QT intervals are more in elderly women So that we need to remember based on psychopathology, pharmacology. Some psychiatric illnesses are more prevalent in women, and the progression is different in women, especially anxiety disorders, where they present with more somatic symptoms to the general practitioners or to the psychiatrists. And the role of estrogen is important in discussing about psychopharmacology. Women have increased gastric emptying. So what it means is drugs, when they take longer time to get absorbed. So their peaks are different than men. The motility and absorption rates are different in women. They have a lower body weight, they have higher body fat and lower plasma volumes. All these determine the psychopharmacology in women. So that's why women are different. And we need to know few things. See, let me tell a blanket statement that psychiatric medications are safer than any other medications. Not that I'm a psychiatrist, but in reality, that is the truth. And we have to vehemently defend our medications. And we need to know our medications. That's what I mean to tell. Right. Women require lesser doses because of the previous factors which I mentioned. I mean, later peak of action due to delayed gastric emptying, lower estrogen levels as a risk factor for depressive and psychotic illnesses. So that we know from the factors, risk factors. And we need to know that there's a second peak of schizophrenia seen in older women, mainly because the estrogen levels are falling in older women. And menopause is a phase which is it's a landmark phase, or you can say the dividing phase. And that's where the estrogen levels fall. And hormone replacement therapy, it helps to lower the psychiatric medications doses, reduces extrapyramidal symptoms and the incidences of tardive dyskinesia as well. So women who have say menopausal symptoms or who have attained menopause, we need to offer them hormone replacement therapy. Yes, so that's the choice which they have, and that can help a lot in psychiatric patients. And in perimenopausal, the symptoms of perimenopausal, I mean, hot flushes or any other say symptoms of palpitations, increased anxiety, tensions, headaches, body somatic symptoms, letharginess, all these respond very well. These are the medications which are FDA approved or they have sufficient evidence, paroxetine, venlafaxine and escitalopram. So these are the medications which are evidence based in perimenopausal women who have perimenopausal symptoms. So we need to know that few things which are peculiar to women as well. Now coming to the second question, 35-year-old woman, so we can go back to the polls again, was responding only to sodium valproate for her bipolar affective disease or disorder and is on 1500
Sorry to
milligrams. No,
sorry to
that's okay.
interrupt
I'll
you, sir.
read.
Again, we will have again the same poll question,
Yes,
and
people can again.
I request audience to again follow the same. Go to the chat box, click on the link. You will be redirected to your browser, and you will see the question. You need to submit the answer, click the answer, and put on send.
Right.
So you just I
So
request
she's on
all.
1500 milligrams daily dose. Now she's 8 weeks pregnant. And what is the advice do you give the patient? The patient has come into your clinic. Terminate the pregnancy and ask them to get pregnant again without valproate. Reduce gradually and stop valproate over a few weeks and switch to another mood stabilizer. Stop valproate suddenly and switch to levetiracetam. Continue valproate after discussing about the options of termination, continuation or risks. And fifth one, I can't see below, or ECT. Yes. So 14 have answered. 15.
Yes, so we will wait for more few seconds.
Yeah, sure.
Please show the results. So maximum response came for first option, that is continue valproate after discussing about option of termination, continuation, risk and etc. And
Right.
now we will see the correct answer.
That is the
So
correct answer.
yes, sir.
Right.
Sir, share your slide again, sir.
Right. Okay. Right. I need to go. Yeah. Okay. Right. So I mean, most of them 82 have said the correct answer. So what it means is always make shared informed decisions with the patient. So the decision is not yours every time, but then give the information to the patient, and more likely the patient will continue on sodium valproate. There are risks with sodium valproate. But let me tell you one thing: neurologists, they prescribe sodium valproate left and right. Right, for every patient on epilepsy, on different types of epilepsies, they prescribe. They don't even think about 18-year-old, 20-year-old PCOD patients. Let me tell you, I've seen all kinds of patients. Let me tell you that. And we don't see that much, say, incidences of, say, what we are afraid of, spina bifida neural tube defects, which are linked to sodium valproate. And yes, according to the literature, the teratogenicity, that is the incidence of, say, neural tube defects, is 7 times than the normal time. Right. So what it means is, if the incidence of neural tube defects normally without on sodium valproate is less than 1%, right? Those who are on sodium valproate, I mean, it increases 7 times of 7%. You can say that, but still 90 to 93%. Those who take sodium valproate, they still don't have, and they're usually on mega doses of, say, folic acid, which say helps further neural tube closure as well. Right. So yes, it's only as psychiatrists I have seen myself that we are hesitant to what is called, the moment we say sodium valproate and pregnancy and women of this, we get jittery and then we try to stop, we try to do lots of things, but then it worsens the whole situation and complicates the whole thing. And postpartum psychosis or postpartum increase of mood disorders, especially people with bipolar disorders, postpartum depressive illness, or even postpartum mania, is higher in patients. So we need to, I mean, there's a what is called as relapse of these episodes in already patients who are suffering from bipolar disorder postpartum. So we need to always cover them up. Remember that. Pregnant women, again, yes, they are completely different. They are 1.5. So what it means is they are one and they already are carrying another child, and so everything increases by 1.5. So they have severe nausea and vomiting, gastric volumes and pH changes are there, drug metabolizing enzymes levels have changed, transporter expression changes are there, altered gastrointestinal motility is there, changes in the weight and body composition, and there is chance of multiple pregnancy. Again, the dynamics change, what medications to give or how much to give, the doses change, increased blood volume, substance abuse. If they have tobacco or alcohol, that again further complicates the dosing mechanisms. Increased intravascular volume, that is 50% increase in glomerular filtration and increased renal clearance due to higher creatinine clearance, sorry. And fetal vulnerability during the first, second, and final trimester. We need to say keep in mind all these trimester phases of the fetus. Right. Now, psychopharmacology in pregnancy, we always preconception, valproate and carbamazepine do have the highest risk of teratogenesis, that has increased in 7-fold, but still, what I mean to say is that comparatively carbamazepine is safer than valproate, and they can be given high doses of folate. If possible, right? If possible, if there's an alternative to valproate, yes, change the valproate. But if there's no alternative, she's responding on valproate very well. Continue with valproate with the cover with informed decisions. That's what I mean to say. And in pregnancy, evidence is there for paroxetine, the teratogenicity when using paroxetine, but remaining all SSRIs are the safe. Risperidone, there is 1 or 2 studies which have, say, reported malformations with risperidone, but according to the evidence, again, the studies which say that 4 milligrams of risperidone, up to 4 milligrams of risperidone, the pregnancies can be safely or equivalent doses of other antipsychotic medications. There are several women who have become pregnant, I mean, who were already on, say, long-acting, say, clopixol depots, or other depots who were there who had safe pregnancy and safe child as well. So what I mean to say is that psychiatric medications are safer in pregnancy as well. So don't be afraid. Always the illness is worse than the medications. So that's what I keep telling you. Now, second generation antipsychotics, there is a risk of gestational diabetes, especially olanzapine we need to keep in mind. Yeah, other medications as well, amisulpride to some extent, clozapine. SNRIs is a caution about gestational hypertension, specifically about venlafaxine. There's always caution of hypertension and venlafaxine, but venlafaxine is dose related. More than 225 milligrams of venlafaxine. In the recent times, I haven't seen any prescription which is more than 150 milligrams of venlafaxine. So let's not be afraid of giving venlafaxine and say correlate it with hypertension. Breastfeeding, lithium and clozapine are contraindicated according to the Maudsley guidelines. So then what to use? Then we'll shift the medications wherever possible. There are other alternatives. Valproate is, you can give valproate also, carbamazepine, everything can be given, provided you tell the patient and it's an informed decision. Low risk of olanzapine, quetiapine, risperidone, and aripiprazole can be given safely in breastfeeding as well. Right. Now again, the third question, we'll go to the third question. A 5-year-old boy is diagnosed with ADHD with normal IQ, developmental milestones are normal, having severe behavioral issues. Now, what are the treatment of choice? Behavior therapy, parental counseling, methylphenidate, atomoxetine, behavior therapy plus parental counseling. So again, the polling has started. People can poll.
I request audience to give the answers.
Yeah. Okay, if people have answered, then we can.
Yes, sir.
Go to the results. Right. So people have gone for atomoxetine is the number one choice, methylphenidate, A and B, and parental counseling. Right. Now, according to guidelines, let me tell you, according to guidelines, any say ADHD molecules or medications are not advisable for people who are less than 6 years. American guidelines, Canadian guidelines, nice guidelines, and then there are age-wise medications can be given. But NIMHANS, there's a study. I attended one of the programs in NIMHANS on ADHD, and we know that ADHD is a neurodevelopmental disorder, right? So what it means is the disease is there from day one, or even during mental phase, or even in fetus it is there. So as early as possible, so that's what I keep advising people. You know the diagnosis, how early can we start, right? So don't be afraid. When you know the diagnosis, don't be afraid to start the medication. It's not like we are starting a disease modifying medications. So atomoxetine acts only on one receptor, but then we have methylphenidate, which is both reuptake inhibitor, right? So DA and norepinephrine reuptake inhibitor. So better give methylphenidate when you're confident that's a better molecule than atomoxetine, right? Yes, we always think of growth retardation on methylphenidate. I'll come to that. So I'll share the slide again. So of atomoxetine and methylphenidate, I'm sure you both agree that methylphenidate is a better molecule, right? But we are mainly afraid of, say, the side effects kind of a thing. Sorry. Right. So in children, in children, neonates up to 6 months, they have decreased clearance, right? Increased metabolic activity from 6 months to 24 months. They have faster renal clearance. See, initially, the body functions up to 1/3 till the age of 3 years or 2 to 3 years, and then it picks up. It increases above the adult phase from 2 to 3 years till 12 years. So that's why there is faster renal clearance from 2 to 12 years. And then after 12 years, during the adolescent phase, it comes back gradually to the adult phase. So what it means is from the age of 3 till the age of 12, they require probably higher doses than the adult doses also. So that's what it means. In liver, oxidation, reduction, hydrolysis that causes the phase 1, and hydroxylation conjugation, they constitute the phase 2. And they function up to 30% till the age 3, and then increases till puberty and reduces back to adult levels. So what it means is children between 3 to 12, they are able to metabolize much better than adults. Children have more body water, increased fat stores, decreased gastric emptying time, and increased tolerance for acidic drugs. So they have less GI symptoms. That's what it means. Decreased albumin and protein binding capacity. Again, what it means is medications or drugs which have higher protein binding capacity. Because the albumin is less, so it binds, so more drug is available for children, and blood-brain barrier is not fully developed. Know that every medication can cross the blood-brain barrier in children. So these are the few points to note in children. And mood disorders and suicide, psychopharmacology of children. As of now, there is evidence for fluoxetine, escitalopram, and sertraline for treating mood disorders and in suicide. Paroxetine is contraindicated. There was a study which found, there was only one study which I could find, out of 738 patients, 25 patients had higher suicidal thoughts. Right, so only suicidal thoughts increased in 25 patients out of 738 patients who were given paroxetine. And then those who were on placebo, suicidal thoughts were present, but it increased to 8, only in 8 patients out of 647 patients. So this is the study which was done, but there was no single case of suicide. What it means is, though they have to mention there is no other studies, fluoxetine, escitalopram, sertraline, they are the safest in children. Medications are safer in children. Give them. That's what it means to say. In ADHD, when you give stimulants, 65 to 75% efficacy of the medications is there by giving stimulants and treating ADHD patients. Methylphenidate, it blocks dopamine and norepinephrine reuptake inhibitors, and blocks the dopamine and norepinephrine receptors. Amphetamine, it increases release as well as blocks uptake of dopamine and norepinephrine. So what it means is, methylphenidate is a better molecule. Amphetamines is much more better molecule than methylphenidate. But yes, amphetamines causes greater growth retardation than methylphenidate. Side effects, usual side effects are nausea, decreased appetite, headache, insomnia, and sometimes rarely tics can be generated by these molecules. And if you take this statistic, this is a study which was done that they cause growth retardation, right? But actually it is 1 centimeter decrease in height if taken continuously for more than 1 to 3 years, right? So what does it mean? So usually people are afraid that it decreases the height of the children. No. So when you take that 1 centimeter is hardly anything, and that too if taken for continuously for more than 1 to 3 years. So our psychiatric medications are always safer. Give them. That's what it means. Atomoxetine selectively blocks norepinephrine reuptake. So it's not a better molecule. It has lesser side effects, but then because we know that the child has ADHD, and we know that, say, methylphenidate is a better molecule than atomoxetine, better give methylphenidate. There's evidence that bupropion and clonidine can also be given. There's also another molecule, guanfacine, but it's not available or we don't give it in India. Right. And in autistic spectrum disorders, when we say psychopharmacology in children, Always we start with a low dose, yes, in children. Patients or those who are on autistic, who have autistic spectrum disorders, we have comorbid depression and anxiety, we can give an additional SSRI. If they have aggression as a symptomatic behavior, give them risperidone, it can be given methylphenidate, clonidine and naltrexone as well. And if they have insistence of sameness or sometimes obsessive kind of a feeling, they can be given escitalopram as well. For those who have oppositional defiant disorder, these are the molecules which are, say, as per the guidelines, risperidone approved. Divalproex and lithium can be given in them. Bipolar disorder in children is from the ages of 10 to 17, less than 10. Again, the guidelines don't say. Lithium, quetiapine, risperidone, olanzapine, but olanzapine is to be given above 13 years. And do not use topiramate and oxcarbazepine below 18 years. So that is what is the guidelines mentioned. Obsessive compulsive disorders, these are the drugs approved and those are the ages where we can use. So clomipramine has been approved for children in OCD who are more than 10 years. Fluvoxamine is approved for those above 8 years. Fluoxetine is approved for those who are 7 years and sertraline for those who are 6 years old. And again, coming to the fourth question. So again, we'll go back to the polls. I think most of you are giving the correct answer. So let us see. A 70-year-old man with complaints of not able to pass urine since 24 hours is confused and in distress. The most likely cause is prostatic enlargement, anticholinergic crisis, not taking fluids, urinary tract infection, and somatic delusions. You can just type the answer in the chat box. I think we can just count. Sorry. So, this question was not in the poll, so that's why probably there's no link for this question. You can just directly answer. I think.
Yes, sir. We don't prepare that
No.
question. I don't think there is some technical issue. So
That's okay.
you, sir,
Don't worry.
You can share from your side and we will discuss it, sir.
Yes, yes. So I think most of them are giving the correct answer. Again, it's anticholinergic crisis. So, and anticholinergic crisis, the most commonest cause again is antidepressants. Right. Coming to elderly, yes, they are different population. We think that most of the organs are gradually degenerating to some extent, and they have comorbid illnesses, and I mean that's what they have, multiple diseases. They are on multiple drugs as well. They have decreased acid production. Again, they have delayed gastric emptying time. So again, delayed onset of action of the drug is there, but then they have the full effect of the drug later. Again, the nutritional status is varies. I mean, because they have less body weight, so they eat less probably, and they have reduced cardiac, hepatic, and renal functions. And in elderly, always, we have to think about electrolyte imbalances, UTI, and the use of benzodiazepines. Their sleep is less. That is known for everyone, that they sleep less than 6 hours. But then we need to know every prescription, every medication they are taking. The benzodiazepines, let me show you one more chart, then they'll know. So this is one study which was of adverse events due to medications. So there was a study in US, and out of a total, I mean, this print is very small because I had to take the short screenshot. So I'll just go through, read. I mean, out of a total 226 patients, and patients who had, say, history of fall, who were admitted in the hospital, right? That is out of 715, say, admissions in a hospital, 43 patients, right? 43 patients were admitted because of drug interactions. And out of these 43, 16 I mean, they presented with false as a reason because of short-acting benzodiazepines, and 17 with long-acting benzodiazepines, and 4 with amitriptyline, right? So what it means is amitriptyline benzodiazepines. So out of 715 admissions, 226 admissions were because of adverse events of medications. 94 of these admissions, they used benzodiazepines, and out of them, the cause of admission was false in 43 elderly patients. So tricyclic antidepressants and benzodiazepines are the culprits in them. The other, say, problems that they have, prostatic hypertrophy, and anticholinergics, they cause urinary retention in some of the patients who were admitted. Fluoxetine can cause increased frequency of micturition. And SSRIs are known. I think every one of us know about hyponatremia because of SSRIs. I'll come to hyponatremia in a bit. Right. So we have to keep our eyes. Every prescription we need to know about elderly. Every medication we need to know. We need to ask them twice, thrice in detail. And pharmacology in elderly patients identify the target symptoms. Usually the complaints of elderly, they're vague. They keep drifting off, but then we have to make them tell us the specific treatments that we need to target. We have to always think about risks versus benefits of the medications that we are prescribing to them because of the effects. Review all medications and check compliance at every visit. So that's what we need to do, especially related to elderly. Algorithm based on comorbidity and drug-drug interactions. I think with every patient we do this. With elderly, we need to be more cautious regarding comorbidity and drug-drug interactions. Take charge. So what it means is, that's what I keep telling you. Psychiatrists are better doctors than anyone else. We do our MBBS. We read every specialty, right? The basics of every specialty we read. We read about psychiatric psychopharmacology. We read about the effects of psychopharmacology, psychiatric drugs on other systems. So we are what is called, we have to take charge of the patient. The patient may have a heart disease, the patient may have a renal problems, the patient may have a hepatic problem or anything. We need to know every medication. We need to know the side effects of every medication which the other specialties are giving. But we need to liaise with other specialties. What I can say, watch is other specialties, they don't know anything about psychiatric medications, and they think that psychiatric medications are the most toxic medications on earth, right? Because they don't know or they're afraid to learn about psychiatric medications. But then they do prescribe, and they prescribe in minuscule doses, right? So we have to take charge of the whole medication list. I think yesterday or today, someone was circulating about around 13 medications in one of the groups, WhatsApp group. 13 medications were prescribed by, say, some physician, I think. Yeah. And out of those 13 medications, 8 medications can be dispensed with. Only the patient can need to be on 5 medications, right? So avoid benzodiazepines and anticholinergics as far as possible. I think as psychiatrists, we don't prescribe benzodiazepines. We do prescribe medications which are symptomatic to the patients and, say, disease, which address the disease, right? So this is in brief about the summary of psychopharmacology of special population. All medications used by psychiatrists are safe. That we need to think about ourselves. Be aware of dose adjustments in women and the estrogen status of the women. With few exceptions, all medications are safe in pregnancy and breastfeeding. Give the required dose. Medications are always better than the illness when compared to the outcomes of pregnancy and the effect on the fetus. Illness has worse effect, starting from preterm labor, preterm delivery, small for age, gestational age child. So all those are, illness does that. Medications are better than the illness. Talk to the doctor, talk to the gynecologist, talk to the patient, talk to the patient's family. Give always informed information, and then let them take the decision. When neurodevelopmental in child, start early. Do not hesitate to start medications in children. Always again, tell them that if you don't start, what would be the course of the illness? What are the complications? Tell them, and then they would automatically give our child the medication. Their distress due to illness is worse than the side effects of the medications. Remember that. Look out for comorbidities and drug-drug interactions in the elderly especially in uses to benzodiazepines, TCAs, and anticholinergics. Now coming to comorbidities. Comorbidities is consultation liaison psychiatry, and it's a huge chapter involving every organ of the body. But then I just focus on say a couple of say specialties and just touch on some points, some important points. I'm sure many of you have not just questions, but many of you know lots of other things which I'm what is called highlighting here. I'm sure we can have a discussion later. There is another question. A 60-year-old woman presented to ER with confusion and hypotension. She has been taking 25 milligrams of paroxetine for her probably depressive illness or anxiety disorder. ECG shows wide QRS complex and right axis deviation. What should be the management suggestion that you can give to the patient? So it's IV sodium bicarbonate, wait and watch, spironolactone, amiodarone, clonidine. Right. So we can see that paroxetine 25 milligrams can cause hyponatremia. So we are replacing sodium. So that's IV sodium bicarbonate is the treatment of choice here, but then it has to be gradually given. I think there was a question recently in the in one of the groups, and the rate of say increase of sodium should be around 6 to 8. So that is the, or less than 6 or less than 8 milliequivalents per liter per day. So the gradual increase should be there, or else there will be demyelination, especially myelinosis will be the central pontine myelinosis and other myelinosis pictures as well. Now cardiac diseases, coming to cardiac diseases, what strikes us is the QT interval, QT interval, QT interval. Starting from the first day of say PG in psychiatry, this has been banged into our heads that QT interval, QT interval. But let me tell you, it's not common. We can give psychiatric medications only when they are drug-to-drug interactions. Already they are taking beta blockers, or already they are taking some other antiarrhythmic medications that can increase, say, the QT intervals, especially in women, and the risk factors are women, elderly women, those who already have a heart disease, those who are already taking cardiac medications. In them, if you try to give antipsychotics, and that to antipsychotics like say ziprasidone or say quetiapine or amisulpride or haloperidol, then we can think of say prolonged QT interval, that too when we monitor that, right? So QT prolongation, what we say, normally in men it is 440, in women it is 470 milliseconds, and greater than 500, or if there is a change of 60 milliseconds from the baseline. So that's what we call it as QT prolongation after taking the medication, psychiatric antipsychotic medication. And usually combinations or higher doses of antipsychotics, QT prolongation is implicated in that. And among antipsychotics, ziprasidone has the highest, does the highest QT prolongation, followed by quetiapine, amisulpride, and haloperidol. Typicals, antipsychotics, they increase the QT intervals more. Latest medications, brexpiprazole, cariprazine, and lurasidone, they appear to not have any effect on the QT interval, right, as per the evidence. Now, antidepressants, paroxetine, fluoxetine, and sertraline have no effect on the QT interval. Higher doses of escitalopram are known to cause QT interval prolongation. Now, we need to again think about psychiatric medication like TCAs, clozapine, chlorpromazine, which can cause hypotension. I mean, when I was in my PG days, at that time, chlorpromazine injection was present. That is around 20 years back. And I used to remember that the patient who is very aggressive, right, who has manic episode, bipolar manic episode, we used to give chlorpromazine injection, and he used to lie on the floor, keep shouting throughout the night, but he couldn't lift his hand or leg, because the moment he gets up, he used to have hypotension, he used to fall down to the ground, right? So that was the medication that we used to give, chlorpromazine. Be cautious about olanzapine and mirtazapine, which can in some patients cause peripheral edema, right? So just be aware of this side effect as well. And clozapine regarding myocarditis, very rare. I haven't seen patients with myocarditis who are on clozapine. And there's another question. 32-year-old man with schizophrenia is admitted to ER with coma. Blood glucose levels, that's unconscious. Blood glucose levels at admission are 467, urine dipsticks, not dipstick, dipstick showed high levels for ketone, positive for ketone. Most likely medication that could lead to this condition: amisulpiride, quetiapine, risperidone, olanzapine, aripiprazole. Right. So let me see the chat box if there are any correct answers. Right. Yep, great. All have answered olanzapine, and that is
Maximum
true.
has answered olanzapine, sir.
Olanzapine, that's true. I mean, it's an obvious. I think we know that. Everyone, every psychiatrist knows that. So olanzapine, yes, in 2001 or 2, when it was probably first introduced in our hospital there, I did see the patient who had diabetic ketoacidosis. Right. So yes. So when you come to endocrine disease, diabetes, aripiprazole and lurasidone are supposed to have least effect on the glucose metabolism, or they're given in patients who have diabetes, comorbid diabetic illness. About lithium, we need to be aware that it can cause, most commonly it causes hypothyroidism, and on chronic use, there are reports that can cause hyperthyroidism as well, right? But then that shifts back to hypothyroidism again. So I mean, we need to just remember that lithium can cause hypothyroidism. Amisulpride causes the highest prolactin increase with all kinds of disturbances in the menstruation cycle. Risperidone, first generation antipsychotics, TCS can also cause prolactin increase, and aripiprazole is given in those patients in whom there is increased prolactin. Right, because of these medications, we change to aripiprazole, and we need to know the metabolic effects of all antipsychotic medications can contribute to obesity and the state of obesity. Right. Now again, there's another question. Drugs most common and notorious to cause agranulocytosis is. So again, people can go and answer in the chat box. Clozapine, chemotherapy, analgesics, anti-inflammatory, carbimazole, calcium channel blockers. Drugs most common and notorious to cause agranulocytosis.
Mostly people have told clozapine and chemotherapy.
Chemotherapy, right. Well, if you take these three, and let me come to, I mean, if you take the choices which I have given, chemotherapy is the answer, the most common notorious to cause agranulocytosis. Next common is analgesics and anti-inflammatory. And after that, it is carbimazole, and after that, it is calcium channel blockers, and after that, it is clozapine. So what it means in the list, clozapine is the least to cause agranulocytosis. Remember that. And the incidence of clozapine to cause agranulocytosis is lifetime prevalence is 0.38%. So which is less than 1%, right? And typically clozapine, if it causes agranulocytosis, in the very first, say, year, 0.7%. So that is less than 1%. And overall, in the first 2 years, it is around 1%, you can say, right? So we always keep thinking that clozapine is the most dangerous medication, and we need to give it with caution, and we're afraid to use clozapine. No, again, let us not be afraid to give clozapine. Let us give clozapine left and right to patients who deserve them, right? So clozapine is the safest molecule. We need to look at calcium channel blockers, right? I mean, cardiologists use them left and right without thinking about side effects of agranulocytosis by calcium channel blockers. But clozapine causes less than that. So that's what it means. So how they use calcium channel blockers, we can use much more common than that. So that's what is clozapine means, right? So we need to know everything about clozapine, how safe clozapine is, where it can be, what is used with caution. So that is necessary. But yes, clozapine is the safest molecule. Prescribe them, right? So that is one. So that we need to know. Neutropenia is other molecules that can cause neutropenia. We need to be aware of these molecules: metazapine, sertraline, all antipsychotics. Mood stabilizers that we know usually occur in the first few weeks to months, right? Thrombocytopenia, which can lead to donazepam, antipsychotics, mood stabilizers, and TCS and NRIs, SNRIs. These can cause thrombocytopenia. Just we need to be aware of them. So it is much more rarer, but then we need to be aware that these can contribute to thrombocytopenia as well. And compared to, coming to what is called as gastroenterology, it's a huge system. So many organs are there, so many systems are there, so many what is called divisions are there in the GIT itself, but I can't cover all of them. So these are the significant points which I felt that I need to know, or I can convey you to you. So GERD, so TCAs cause most effect on the GERD. They relax the GE sphincter and cause more acidity. So antipsychotics also relax the GE sphincter. GI bleed and the role of SSRIs. There are studies where SSRIs have been implicated in increased GI bleeds, right? But it's an observational studies and not actually evidence-based per se. Right? So these are observational studies which have said that SSRIs can contribute to increased GI bleed. No direct linkage to them. Nausea and vomiting, that we need to remember in GIT, we need to think about the cyclical vomiting syndrome. And it is common. I've seen patients, especially women, and in pregnant women also. There's a difference between hyperemesis gravidarum and cyclical vomiting syndrome. That we need to differentiate between those two. And chlorpromazine has been a very good molecule in treating these patients. And to some extent, even imipramine has been useful in treating this patient. Now, upper GI neuronal functional disorders. So I don't call them functional upper GI disorders. I want to call them upper GI neuronal function disorders. So that's what we are talking about. This is our field. Let's not give the gastroenterologist a scope to hijack this field as well. Right? And escitalopram has a prokinetic and procolonic effect. So it has been very useful in treating patients with upper GI neuronal function disorders. IBS, diarrhea type. So SNRIs, especially venlafaxine and desvenlafaxine, has been very useful in treating patients who have anxiety symptoms as well as depressive symptoms comorbid with IBS symptoms, diarrhea type. And the effect of venlafaxine or desvenlafaxine, we know that it's constipation. So that can help in treating those patients, and several patients have been nearly cured of, let me tell you that, of IBS diarrhea type. And there are other patients with IBS constipation type wherein SSRIs, paroxetine, sertraline have been useful in them, especially in mixed roles as well, in mixed cases, IBS mixed cases. And liver disease, there's studies that 1/3 of patients with psychiatric illnesses on medications have abnormal LFTs. So do we need to be afraid of them? No, we need not be afraid of them. So that's, we need not be afraid of even abnormal liver enzymes, right? Only if the enzymes are more than 3 times, and if the serum bilirubin is more than twice its normal levels, only then we need to think about our medications or change of medications or decrease the dose, right? Sometimes there are idiosyncratic reactions and not dose dependent also. I'm not touching on alcohol dependence and psychopharmacology. I think we know about GIT, alcohol, liver issues, and psychopharmacology about that. There are some symptoms in GIT, dry mouth and constipation, which can be caused by anticholinergics. All antipsychotics can cause, and all antidepressants can cause them. And we know how to address these symptoms as well. Now, coming to renal system, urinary retention, mainly the anticholinergic action. I think many of you have given a correct answers for this. Anticholinergic action of antipsychotics as well as antidepressant medications. Urinary incontinence, that is increased. So stress incontinence is mainly present in use of antipsychotics. The other types of urinary incontinence, urge, mixed and overflow, again antipsychotics are not, or psychiatric medications are not involved there. Polyuria, again we need to think about say diabetes insipidus, especially lithium. Hyponatremia, there are again 3 types of hyponatremias are there, which can be, hypovolemic, especially when there is loss of fluid and then the sodium also is gone. Euvolemic, especially caused because there's no change in volume. Majorly psychiatric medications are implicated in euvolemic hyponatremia, especially SSRIs. Hypervolemic, that which occurs in say cardiac failure, hepatic failure, renal failure. So those are the hypervolemic, wherein there is fluid retention is there. Now, chronic kidney disease and lithium, right? So we need to think about patient. There are patients who have developed chronic kidney disease, especially when lithium is given to them, and especially interstitial nephritis. Say what is chronic glomerular nephritis and chronic interstitial nephritis. So then, we have to withdraw the lithium and give them some other molecules, especially in patients with bipolar disorder. And patients who are in carbamazepine, who develop, say, CGN and CIN, lamotrigine can be used. So they can be changed to lamotrigine because lamotrigine is less cleared by their kidneys. Now, in patients with CKD or say end-stage renal disease, again, escitalopram and mirtazapine of all the antidepressants do have increased renal clearance, and hence we have to give them at half the dose. And remaining antidepressants can be used as normal. Risperidone and paliperidone excrete up to 70% in the renal through the renal, and hence long-acting preparations are contraindicated if the GFR is less than 50 millimoles. Amisulpride 2 should be avoided in these patients. Lorazepam can be used in patients with renal failure because of the hepatic clearance. And in transplant patients, there is a note that to avoid carbamazepine because it inhibits CYP3A enzyme system, and hence the effectiveness of immunosuppressants will be lost. So post-transplant use immunosuppressants, that will be lost, so there will be greater graft rejection in patients with transplants. And about sexual dysfunction and psychiatric medications, premature ejaculation, and we know the role of SSRIs, and depoxetine is widely used, but then we tend to use even other SSRIs as well with very good results. Drugs with less sexual dysfunction, vortioxetine, aripiprazole, bupropion, brexpiprazole, cariprazine, lurasidone, buspirone, mirtazapine, and duloxetine. So we have so many choices with patients. We can give all these medications, those who complain of decreased sexual function. Drugs with more sexual dysfunction, first generation antipsychotics, second generation antipsychotics, SSRIs and venlafaxine as well. So that we need to think about. And then we have choices of we can use sildenafil, tadalafil, and testosterone as well. And the hypoactive sexual desire, especially in men, there is evidence that bupropion is effective, and in women, flibanserin, I think flibanserin is not available in India as of now, I don't know, but then it is available elsewhere. About role of infections, antibiotics like quinolones can increase or decrease the levels of antipsychotics because they increase the metabolism and can cause prolonged QT prolongation as well. So every time the QT prolongation, we do not think about our psychiatric medications. Antibiotics can cause, ciprofloxacin can cause. Quinolones especially can trigger psychosis, insomnia, and anxiety related symptoms. Rifampicin reduces the levels of psychiatric medications, so we need to give more doses, or there will be a relapse of the illness. INH, especially used for anti-tuberculous medications, it itself can trigger manic episodes and can to some extent lead to serotonin syndrome as well when drug interactions with SSRIs. So that interactions we need to be aware of. These are the few things. And antivirals, there is a risk of QT prolongation again. Reduce the levels of psychiatric medications, and special caution with ARD medications. So ARD medications, few of them, so we give a combination of 3, and they can, if you are giving SSRIs can be given safely, but then there is a risk of bit in patients, the reported cases of serotonin syndromes as well. But then if that is the case, then we can always give safely bupropion as well. Right. So I'll stop or end my talk here. So this is just a conclusion. Psychiatric illnesses do more harm, they do more harm to the patient's physical, financial, social, family, and health of the nation. Overall, psychiatric medications are safe in all special populations. We need to know about these. Minor exceptions should not deter anyone from treating the illness aggressively. Always be informed and keep the patient and their family members informed, collective, shared decision. So that's what, you remember these words. We always have to do that. Look out for comorbidities and drug-drug interactions. Always ask for comorbidities, illnesses, and current medications at least 4 to 5 times. Always recheck. Ask them. They always keep telling, "Oh, I forgot to tell you. I also take this, and I also take this." And by the time they end up their list, beginning from when they said that, "No, I don't take any other medications," they end up with taking 7 to 8 extra medications per day. Right? So we have to ask them more times. Thank you very much. So,
Few questions are there in the chat box.
yeah, definitely. Right.
From Chirag Shah.
Right.
They've seen some initial worsening of behavior symptoms while giving methylphenidate. What is your experience or others' experience, sir?
Right. I mean, methylphenidate is known to cause it's not like worsening of the symptoms. What I can say is that they may not be responding to methylphenidate, or yes, methylphenidate itself can cause initially increased anxiety symptoms that may translate as behavioral symptoms. Try talking to the parents, try insisting on continuing the medication, and if truly the symptoms are worsened, if it's persistent, change the medication to amphetamines or atomoxetine, some other medication. Yes.
From Jagdish Verma, please comment on use of melatonin in elderly as compared to benzodiazepines or zolpidem for sleep disturbances.
Right, I know melatonin is the favorite medication nowadays, but the dose of 3 milligrams or 6 milligrams doesn't touch anyone. We need to give in the doses of 10 milligrams. But again, the half-life of melatonin is less. So it's around, the moment you give melatonin, within 1.5 hours, so you're supposed to fall asleep. So what it means is melatonin is a good sleep initiator, you can say, but not sustained. We need to divide the sleep into, say, what is called as initial insomnia, middle insomnia, or late insomnia. So when they are having the sleep disturbances, so we need to give medications based on that. So it's melatonin itself, only if they have circadian rhythm disturbances, especially people in patients with, so those who are in ICCU or MICU, or those who have dementia. Right? It's not a routine medication that can be given for sleep. So primary cause of the sleep has to be treated, and then we need to divide the sleep into, say, initial insomnia, middle insomnia, or say later insomnia, and then give medications which act on those types of say sleep structure accordingly. Yeah. So,
okay, sir. One more question is there, that what dose of aripiprazole is recommended for reversing hyperprolactinemia caused by other drugs, if you don't want to change the primary medications?
Right. So hyperprolactinemia, see, if they have galacturia, if they have disturbing, say, menstrual disturbances, right? Amenorrhea is such a distressing symptom sometimes in patients. They feel that, some patients say that amenorrhea is okay for them and they are continuing on the same medication because they have responded and they're working. But there are some patients who say that amenorrhea is causing weight gain as well, and it's a distressful situation. So we can reduce and stop and put them on other medications, especially aripiprazole. If you have to give a combination of, say, both medications, so I haven't given, let me tell you, aripiprazole with other medications, but probably in the dose range of 20 to 30 milligrams. It's a hit and trial method. There's no other, say, evidence based that such a dose of aripiprazole, suppose they're taking 400 milligrams of amisulpiride, and which is causing severe hyperprolactinemia as well as amenorrhea, and what dose of aripiprazole needs to be given to reverse that. So there's no studies per se or evidence per se, but probably a higher dose we may expect. But we need to, say, what is called as decrease the dose of amisulpiride.
Yes, sir. Paresh, sir.
Hello, can you hear me?
Yes, I can hear you.
Yes. Elderly patient who has undergone CABG and who is on
Yes.
statin. So in that patient, which antipsychotic is safe or less harmful, and which antidepressant is safe or less harmful?
Wow, that's a very generalized statement I can give. So the basic thing is CABG is there, so it depends upon the ejection fraction whether they have what is called as the failure is there or not, and how much of failure is there. And antipsychotics to give given those who have less metabolic side effects. So if they're already on statins, they will say hypercholesteremia, then aripiprazole can be given, so lurasidone can be given, or the newer molecules. If they are available in India, when they come into India, then we can give those medications. But probably not olanzapine or say risperidone, which can say increase the metabolic effects, including hypercholesteremia. Now, antidepressants per se. So there are studies that post say event, cardiac event, sertraline is one and venlafaxine is one, which have say what is called as the increased heart rate variability, which is much more safer in those by using those medications compared to other antidepressants. Like so, evidence is there for sertraline and venlafaxine.
It should be avoided.
No, they can be given.
It can
Sertraline
be
and
given.
desvenlafaxine or venlafaxine can be given safely.
Okay, right. Thank you.
Mania sir.
I would like to one or two comments. In IBS-D, you mentioned about venlafaxine. We many times use amitriptyline. What is your opinion? That is one. In PME, clomipramine is also drug of choice, which we regularly use. And the third, in bipolar patient in children, you have not selected valproate. Any problem? Because there are a number of reports that valproate would be the drug of choice in children and adolescent bipolar. Dr. Vadlamani.
Yeah. So let me answer first. IBS-D, no, tricyclic antidepressants, amitriptyline is the treatment of choice. I don't say treatment of choice per se, but because the side effects of tricyclics, both clomipramine as well as amitriptyline, are distressing. So we have an option of giving, say, venlafaxine or desvenlafaxine with lesser side effects compared to TCS. So that's the reason why I mentioned venlafaxine. It's not that you should not use amitriptyline per se, right? That is one. And second part is studies have shown that when you take OCD, clomipramine is less, well tolerated compared to other SSRIs. So what it means, there are more side effects of clomipramine. That's why clomipramine has gone down the list of choice treatments with patients with OCD. Though it is say guidelines mention or the evidence mentions that clomipramine is effective, but then when you say IBS, diarrhea type, we have to use higher doses. So higher doses means again the side effects of those medications will be more. So that's the reason why I mentioned about desvenlafaxine or venlafaxine for IBS. The second question of bipolar disorder in children, right? So it's not like I haven't I neglected or sodium valproate, but yes, what I wanted to say is that I want to mention about the more efficacious of lithium can be used safely in children as well. So that's the point I wanted to stress. Yes, sodium valproate can be used, especially in children, boys. So usually I tend to avoid using sodium valproate in girls, especially adolescent girls.
Thank you.
There is one more question. Sir, any clinical experience on lithium being used to treat drug-induced thrombocytopenia?
No, let me tell you that I haven't used lithium to induce thrombocytopenia now. Right.
One more. If patient is on lithium planning for pregnancy, how one should approach?
Right. Epstein's anomaly. So that's what people are afraid of. As of now, evidence for lithium and teratogenicity is extremely less. Right. So that is one. And Epstein's anomaly is a heart-related anomaly which is present in children, and they have associated with lithium. So what it means is there is no direct correlation from lithium to Epstein's anomaly. But then there are studies that if the patients have genetic vulnerability to Epstein's anomaly, they will develop. So what I would suggest is use lithium left and right. So that's what I mean to say that. So don't be afraid to use lithium even in pregnancy. and tell them, but it's always should be an informed decision. That's what I keep telling people.
Yeah.
Tell the patient, tell the, say, pregnant lady, inform their family members about the information and about the relapses. The illness is always worse than the treatment.
Dr. Mahesh Desai, sir.
Yes, sir.
Sir, good afternoon. We plan to appoint you as a brand ambassador of Psychopharmacology IPS, sir.
Sir.
Thank you very much for a very good lecture. My question is, sir, that we see leukopenia with a lot of problems in our Indian setup. You know, viral infection or any small thing, and the patient comes with a report of reduced WBC count.
Right.
So, some out of fear, you know, I don't have guts to continue clozapine even if the patient is doing well. So, what is your experience of retesting and trying clozapine again? Have you tried it, and what is your experience, sir?
I mean, the levels of leukopenia, that's what we need to measure. If it is less than 3000, then we have to reduce the dose of clozapine. Need not stop clozapine altogether. See, I mean, I have used clozapine up to the doses of 900 milligrams. So let me tell you that, right, without any side effects. There could be minor side effects, but the effect of what clozapine is useful to that patient is miracle, right? So we need to monitor the leukopenia. I mean, the basic thing is if it is less than 1500, then we have to stop. If it is less than 3000, we have to, say, reduce the dose of clozapine if it is directly correlating to clozapine. But if it, I mean, if you say 10,000 is normal levels or 7,000 is the normal levels, and if due to viral load, if it is, or say some viral infection, if it is less than, if it is around 5,000, I wouldn't hesitate to start clozapine, but always monitor if you want. We have the schedule for monitoring. So once a week we can monitor while increasing the dose. We don't start clozapine immediately at 100 milligrams or 200 milligrams or for 300 milligrams. We start at 25 milligrams and gradually build up on a weekly dose. So we can monitor the blood levels and leukopenia, I mean the WBC levels, and then if it is really attributed to clozapine and if the WBC counts are decreasing with increasing dose, and that too if it is less than 3000, then we decrease the dose of clozapine, and if it is less than 1500, we stop it.
But sir,
Okay.
once we stop it, sir, and then again after some time.
Yeah, we can re-challenge with clozapine. And
yes, re-challenge I am asking about, sir.
Yes, sir. So we can re-challenge with clozapine, and it has, the evidence is there that after, I mean, there was a study in which 37 patients were re-challenged with clozapine, out of whom 8 developed what is called as leukopenia again, but remaining patients did not. So it means that clozapine can be re-challenged, and then if it is not causing leukopenia, then we can continue with clozapine.
In continuation with same, sir, I got one patient from Sweden recently where because of tachycardia they just stopped on 150 milligram clozapine. Patient was told that after 150, if we try to increase, your heart rate increases, so we cannot go beyond 150. So shall we stop on those dosages, or we should use propranolol and continue?
Right, it's a very good question. I haven't think out, and probably it's a case-to-case basis we need to decide. Right, provided if there are no other, say, contraindications, I think we can increase the dose, and like you said, we can add propranolol and continue the treatment. That's a very good suggestion as well.
There is one more question. Any dose adjustment for lorazepam if it is used in patients with renal failure?
Renal failure? No, I think there is no evidence that lorazepam has to be reduced in patients with renal failure.
Okay, thank you, sir.
Right.
We don't have any more questions in chat box. Anybody would like to raise hands, then they can. Otherwise, we'll conclude.
Yes. Can I?
Yes, sir.
Yes, sir.
Sir, you have given good idea about the treatment in children, but would you like to give some tips for geriatric group regarding psychopharmacology? What are important points we should keep in mind while treating the geriatric patient?
One thing
Important
is, yeah, one thing is comorbidities. Always look out for comorbidities. They will not tell you. They'll tell, I don't have glucose, I don't have blood pressure. But what they mean is, my glucose levels are normal, I'm taking medications. What they mean is, my blood pressure is normal, I'm taking blood pressure medications. So that's what it means. I don't have means. So that's what we need to keep asking 4 to 5 times to them. What medications are they taking? So comorbidities we need to ask. Right, we need to ask about drug, what all medications they are taking from A to Z, including pantoprazole, including, I've seen so many patients who were on, they start taking acid medications. So what acid medications are you taking? They said, I'm taking PAN. So then they said, I even went further, can you show me the tablet? Then what they take is that PAN L, which has levosulpiride. And that is what is the culprit somewhere, which can cause some distress again. So we need to go into deeper and deeper. We need to see the medication with our own eyes till we, what is called as, decide about, especially in the elderly people. And elderly people do have side effects. And like I said about one of the studies, benzodiazepines have been implicated in the falls in elderly patients. So as far as possible, make them wean away from benzodiazepines and tell them the what is called effects of benzodiazepines. You can, psychiatry has wonderful medications which can help them sleep, right? Only for that kind of medication. But typically, these medications are restarted by other physicians, cardiologists. Alprazolam is written left and right.
Hello.
That is, yes.
Hello.
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 Yes,
Sir, you
Asim
can
bhai.
continue.
Yeah.
Hello.
So these are the
Yes,
tips.
sir, you can
what I
continue,
said.
sir.
Yeah. So these are the tips for, I mean, especially in the elderly. I mean, you can start always, I mean, there's a typical algorithm is there. Start a low dose medication, start the least number of medications. So, I mean, if two medications, I mean, if one medication can solve, say, 2 symptoms, so better give that only one medication with anxiety, or which can address 2 symptoms at one stroke. So these are some small tips that we can use in elderly. I think every one of us does the same thing, right? But then, especially regarding elderly, I always tell comorbidities, look for drug-to-drug interactions, always enlist the number of medications and take charge.
Yes,
Because-
Manya sir. Yes, Manya sir, you can.
I would like to add to, of course, the things which you added last. I think that should be the first. Start low and go slow. I think that should be the primary thing in geriatric population. First thing, start low and go slow. Second, definitely other illnesses with other medications patient is taking. Third, as far as possible, see that this patient, the drug does not cause postural hypotension. Otherwise, there will be fall, fracture neck, femur, and usually they die because of that. And
Yes.
fourth would be we should use the minimum drugs, number of drugs, and the drugs which is causing anticholinergic side effects should be used minimum possible. But the first and foremost would be start low, go slow. And probably because of their metabolism, they might require less dosage because all their organs, including liver, kidney, heart, are comparatively weaker. See, my body organs would be much weaker compared to yours, and I might require little less dosage because my liver, kidney, everything is working less. Thank you.
Very true, sir.
Thank you, sir, for excellent feast. And I would like to request Dr. Paresh Shah, sir, to give concluding remarks.
Hello, can you hear me?
Yes.
Yes, sir.
It was excellent presentation by everybody is enlightened by your talk. Important point for us is how to deal with comorbidity and pregnancy. So you rightly and nicely narrated all the things, and question answer session was very interesting and everybody is really happy. Thank you, sir, for very nice lecture.
I would like to thank the organizing committee for honoring me to be a speaker in this annual conference of Gujarat State Branch. And let me tell you that more than half of the Gujarat State Branch psychiatrists, I know them very personally, and Gujarat, Ahmedabad or Hyderabad are like twin cities. Like, thank you very much.